Heard quotes by Martin Luther King Jr., you've heard quotes by Ronald Reagan. I'm going to give you a quote by Groucho Marx, or at least a paraphrase. I'm always suspicious of any panel that would invite me onto it, so I'd share that with you. I don't know what I was thinking when Melissa asked me to come up here. I thought I'd just sit up and just listen to what's going on. I didn't realize until about 15 minutes ago that they're going to ask me to speak. So that may make this either a very short or very long presentation. From a primary care point of view, we probably do everything wrong in our office, and that may actually be more instructive than having somebody tell you what everything right is. And my only concern is that I'm wondering which one of you guys are going to arrest me at the end of this talk. The good news is I live in Dover, I have patients in Rochester, and I practice in Portsmouth. I figure while they're fighting over who's going to actually put the cuffs on, I can sort of sneak out on the way. And I hope that you'll take these remarks as in terms of honesty and openness as a cause for learning, as a cause for how to approach this in a better manner. Clearly, what we need more than anything else is good communication. And standing in the way, well, not so much, but a little bit, are the HIPAA laws. And I'm not against HIPAA, I think it's a great thing. But we do want to be careful protecting patients' privacy, protecting patients' rights. At the same time, we want to be able to communicate with emergency rooms, other physicians, the police, so that we're doing the right thing. And it's very difficult to do. I know that my best friends actually stood up here, Dr. O'Connell, Dr. Pease. What I've done over the past, 5 or 10 years or so, is I've actually prescribed less opioids because we do have pain clinics around. And because I know we do a terrible job. In our office, we do not do urine monitoring or drug monitoring that way. We don't have contracts that we sign with people, although I have to tell you, there's a lot of implicit contracts. If people are stealing prescriptions or if we caught them doctoring prescriptions or whatever, they're simply out of the practice, and they kind of know that. But still, many of the basic fundamental issues that should be addressed really aren't done in the office. I can't tell you how many times I've walked into an exam room and found one of my colleagues' prescription pads sitting right out there on the table. And I'm like, okay. It's taken me 3 or 4 years to convince my colleagues that when they're on call, don't write or don't authorize any prescriptions, any narcotic prescriptions for any of my patients. I need to take care of that, and if I haven't, I'll address it the following day or on Monday when I come into the office. If I'm on vacation, I tell my patients, look, I'm going to be on vacation for this length of time. Either you get your prescription before I leave, or they're not going to be available to you until I get back. That sometimes doesn't always work. Because I've got colleagues who are excellent physicians. They've been in the community for years. Frankly, I think they're better doctors than I am, if you want to know the truth. But they have really old-fashioned ideas about how to treat patients. And a lot of times, some of these patients, newer patients, come in and they're very good at snowing us. They're very good at telling us how to get away with things and so on. Well, they don't tell us how to get away, they just have to do it. What was most difficult for me is when one of my colleagues decided to retire. And suddenly I had this whole influx of patients coming in, many of whom were on narcotic medications. And the documentation wasn't always very clear as to why they were taking medications in the first place. And that presented a huge challenge for me because I didn't want to create a lot of bad blood between myself and the patients. On the other hand, I had a lot of patients that I just clearly didn't understand why they even needed a pain medication in the first place. They were getting them for years, and the documentation about what the problem was simply wasn't there. And I'm not sure I'm happy or sad to say that I've lost a lot of those patients. They've gone elsewhere. When I said, well, I've been doing this for years, why are you telling me to do this? I thought, why are you getting this drug? And they simply, well, I had a doctor in Virginia that said I needed this. I said, wait a minute, you've always lived in New Hampshire, you had to go to Virginia to get a diagnosis. Where's the notes from the doctor from Virginia? Well, they're in the chart, and I said, here, you find them. I can if I'm going through, 10 years, 12 years of notes, couldn't find anything there. And he left. I had another patient came in. This is a new patient. This is actually a good story. Lady came in, pretty nice looking lady, comes into the office, had fallen down and hurt her tailbones, considerable pain. So I did a brief exam, really couldn't find any evidence that there was anything actually going on here. And she, you know, the bad news about drug addicts is they never come in with the tattoos over their forehead. I'm a drug seeker. It would be nice, you know, I'm not sure that's legal, but it would be nice if that happened. But there are certain signs that come through, and this one, you know, well, I tried different, you know, well, how about ibuprofen? No, that doesn't work. How about naproxen? No, that doesn't work. Well, what does work? Percocet. Really? So I said, well, let me take a look. So I examined her, I couldn't find anything. I decided against, because it was the first visit, I decided I would give her a shot of an anti-inflammatory ketorolac, Toradol. And one of the things I do, I'm kind of weird, I guess, is, as I said, I do everything wrong. When I clean off the area with alcohol, I'll also just swipe across the back, the lower back, because I like to let the alcohol dry before I actually put the needle in. It's a courtesy, it just doesn't hurt as much. And so I swiped across, and I noticed, gee, I don't even see a bruise here, there's nothing here. And well, she came in the next day because I didn't give her the narcotics the first day. And so I said, I was still waiting for old records to come in so I could treat something. And this time she had a bruise, blue, and it was pretty interesting. It was flat, but it was a bruise. So I did my same thing. I cleaned off the area and I swiped across the alcohol, and the bruise came off. And that was the last time I saw her, too. So I think if there's some way that we could talk to other physicians, if we can, again, with the drug monitoring program, I think it would make my job a lot easier. There's a few things that I think that I do right. I have a number of patients that I just, if you're a doctor, you know this. There's a few patients that you have in your practice you just don't know. They're there, they're on medications you're really uncomfortable, they've been on them for a number of years, and you're just really not sure. These are patients I've had for years. I've been prescribing drugs. I think they're drug addicts, but I can't really prove it. And my problem is I always give people the benefit of the doubt, which means I've walked the broken bridge several times. And so I'm never sure. I have probably, I'm guessing, about 5 or 6 patients, or maybe more, that I really truly think are drug addicts. And I'm never really quite sure what to do with them. And that's why I like the pain clinic. They're always there to help me out. And with all the new people, I sort of bring them in. But it'd be really nice to know if there's some way I could contact, I'll contact their pharmacy, but I'd like to contact their former doctors. I wait for records to come in before I prescribe any narcotics on new patients. And that I find very helpful. The other thing I do that, I don't know, with these patients I'm talking about that are chronic prescribers or prescribees, I guess, is I keep them in my practice. As much as I'd like to get rid of them, as much as I don't trust what I'm doing with them, I figure that the community in general is safer if there's just one doctor prescribing medications for them, if they're not shopping around. If I can at some point prove that they are in fact illegitimate, pain drug managed seekers, then I'll get rid of them. And when I do, I can then send out signals to prescribers that, hey, here's somebody to watch for. But in the meantime, I sort of hang on to them, not because I want to, but because I think I'm doing something positive for the community by not getting them to shop around. And again, whether that's the right thing to do or not. I spent a number of years on the New Hampshire Academy of Family Physicians. I was on their education committee for a number of years, and I've always tried to include some sort of drug management program. But even then, with the medical academies, a very small percentage of doctors actually show up for those things.